Illinois, and this is Professor Issam Moussa. So as many of you know, Dr. Moussa is currently the medical director of the Carle Heart and Vascular Institute. He's also clinical professor and head of the Clinical Sciences Department at Carle Illinois College of Medicine, and he is co-lead of the Carle Illinois Neurocardiology Research Initiative at the Beckman Institute. More on the latter in just a second. So Dr. Moussa completed his medical degree at Damascus University in Syria. He then completed his postgraduate training in internal medicine, general cardiology, and interventional cardiology at Georgetown University Medical Center, the University of California-Irvine Medical Center, and the Lenox Hill Heart and Vascular Institute in New York City. Dr. Moussa then pursued formal innovation entrepreneurship training at Stanford in the Biomedical Innovation Technology program, and he completed an MBA in healthcare administration at the University of Colorado Business School. Prior to joining us here at Carle in Carle, Illinois, Dr. Moussa was clinical chief of cardiology at Rutgers, as well as professor and chair of the Division of Cardiovascular Diseases at the Mayo Clinic. So Dr. Moussa currently serves on Healthcare Innovation Leadership Council of the American College of Cardiology and is the co-chair of the Digital Health and Medical Devices Working Group. He works as an interventional cardiologist and specializes in performing complex catheter-based cardiovascular procedures in patients with coronary artery disease, structural heart disease, and peripheral arterial disease. He's co-authored more than 200 peer-reviewed articles, and he's participated in more than 100 clinical trials. His current research program is focused on an area that he personally helped pioneer. So he is a global recognized leader and pioneer in the emerging area of neurocardiology. This fascinating question of how are our hearts and our brains connected? And Dr. Moussa was one of the first to recognize this very exciting interface and has pioneered our understanding. And the more we learn about this space, the more I think interesting it gets, that there's tremendous connectivity here. And Dr. Moussa is really leading the world and helping think about how we can understand it. And ultimately, of course, how we could harness that understanding to hopefully improve the lives of patients. Dr. Moussa, we're thrilled to have you here today to tell your story and really looking forward to your talk.
Thank you very much, Marty. And again, thank you everyone for the opportunity. Obviously, I consider it an honor to be given the opportunity to share with you this topic, and again, to engage with campus and clinical faculty and to push this forward. So first, I wouldn't take credit as I'm pioneering worldwide. I could say from cardiology perspective, probably I am. You know, this field been obviously investigated by neuroscientists and others for quite a while, but I think translational aspect still very still early in its infancy, and not too many physician scientists are involved. So I think it's a multidisciplinary area that require all of us to work together to advance. So the topic here is heart attack. Do heart attacks cause brain inflammation? And I'm using the sort of term cardio-neuro-immunology. That's sort of a new term because usually you see neuroimmunology or cardio-immunology, but not cardio-neuro-immunology. And this is kind of the topic of discussion. Now, when I go nationally and talk to my cardiology colleagues, and obviously everybody knows heart attacks, right? When I say heart attacks cause brain inflammation, they say, what do you mean? What do you mean heart attacks? You mean stroke? No, I say it's brain inflammation. So it's like, you know, I've seen this sort of headline, mugged by a parrot. It's kind of, you know, it's kind of unreal, but it may happen. I'm going to share with you some other headlines, kind of just really to put the topic in perspective. I think in translational research is really important to have an understanding of the state of knowledge now relevant to impact on health, and then how the specific research question will address the larger problem. So in terms of cardiovascular disease, in 2015, it's been estimated that there's about 18 million deaths annually from cardiovascular disease. So that's more than cancer and chronic lower respiratory disease combined. In terms of disability, it's estimated that cardiovascular disease burden amounts to about 350 million disability adjusted life years, which means obviously this is the disability burden. So clearly it's an issue that's been with us for a long time, and it's only getting worse, not better, because of the aging populations, diabetes, other risk factors. Another headline, this is from the CDC, but so every 34 seconds an American have a heart attack, right? And with that comes kind of the line below, for many, depression is part of the picture. And we'll see how that connects, why I'm talking about depression with heart attacks. And again, to put more numbers, so about 22 million Americans have depression, and depression is twice as likely if you've had a heart attack. And we'll see from actual epidemiologic studies that, you know, percentage range between 30% and 45%. So although it's a headline, it's not too far from reality. About a third of patients or more with heart attacks who never had depression before will develop depression in the ensuing few years. Not only that, you could flip the coin, and so people with depression without any prior cardiac disease that's known, they have 55% increased risk of having a heart attack. And again, to just show you that this is not just a headline, this is just a recent review, right? Calling this the heartbreak of depression, or the psychocardiac coupling in myocardial infarction, specifically addressing this issue. And again, there's, I would say, many epidemiologic studies, right? This is not sort of a data point on the fringe. This is mainstream in epidemiology that patients with depression are high risk for having heart attacks. And in this same paper, the authors sort of at least attempt to put a diagram how this relationship between major depressive disorder and chronic stress lead at the bottom with having cardiac pathology. And I'm not going to go necessarily in all these details. I will allude to these as we go forward. I'm just going to go over the categories of organs and systems involved because that's relevant to our discussion. So chronic stress, depression affects the brain, specifically in the hypothalamus, and again, activates both the sympathetic system in terms of increasing activity, reduces vagal activity. Also, it activates the hypothalamic pituitary axis, the HPA axis, that would lead to chronic to chronotropic releasing hormone and ACTH that stimulate the adrenal gland, secrete glucocorticoids, right? And we all know steroids, what they do, right? Then you go down, you increase or you activate the immune system. And again, at the bottom here, you see what's increased in terms of the sympathetic activity, epinephrine, norepinephrine, other cytokines, reduced vasal activity, etc., and that collectively increases the risk of cardiac disease. Now, as we see this, let's keep in mind what happened if we flip it. If someone have a heart attack, would this diagram look different? And I think this is what we're going to show at the end, that it really may not look very different. It just, we're going to see that a heart attack may stimulate the same systems that eventually lead to its impact on the brain. So going back to at least, I'm just going to go, so one slide about the epidemiologic studies. And again, there's tens and tens of them. This is just a recent review article that shows the relationship between myocardial infarction and psychological sequelae, psychological diseases. Depression on the top, between 31% and 45%. However, also anxiety, 24 to 37%, and post-traumatic stress disorder, 4 to 9%. I would say this entity is least, I don't think there's sufficient evidence for this, but certainly depression and anxiety, many references on the side clearly illustrating MI is associated. I'm gonna say is associated, not causing, because causality obviously needs a different level of evidence, but it is associated with depression and anxiety with controlling for known psychiatric diseases prior to MI. So they've done their best to control for confounders in those epidemiologic studies. Now, a few years ago, again, along with Beckman Institute and Clinical Research Institute at Carle, they were generous to support establishing the Carle Illinois Neurocardiology Research Initiative, and actually we hired a postdoc fellow to help and to identify faculty on campus to be able to be part of this initiative. And we'll talk a little bit more about that. So before, again, I delve deeper into the issue, I just want to kind of talk about what's the traditional view of heart-brain interaction. If I go and talk to a cardiologist or maybe a neurologist in clinical practice to say heart-brain relationship, what is the understanding of that right now, even those days? So people would say, so the heart is a pump, right? the pump could fail, the muscle could fail, or there could be an arrhythmia, or there could be ischemia. That would result in reduced pump function, which means reduced perfusion to the brain. Atrial fibrillation could cause clots in the heart. Those clots could go in the brain. So the extent of the heart-brain interaction is you could get hypoperfusion and you could get a clot causing a stroke. Now, both these are absolutely true, but I think it's absolutely the tip of the iceberg, right? The actual interaction and relationship go much deeper, even though that's the most common understanding of this relationship. So let's look a little bit deeper into how the heart and the brain connect, right? So when we think about heart-brain connectivity, we try to sort of split it to four, I would say, dynamics, so four systems, even though in the human body, as you know, any biology, we just divide things to understand it, not because things are divided. I was going to talk about the pump and vascular functions. We're going to talk about the humoral interaction between the heart and the brain. We're going to talk about the neurocircuitry between the heart and the brain, and then the immune system. Before we delve deeper again, notice that the pump and vascular function also connect directly or influence and is influenced by the immune system and the humoral system. The same for the neurocircuitry between the heart and the brain. Also, it's influenced by, it affects the immune system and the humoral system. Also, the heart muscle function, it affects the neurocircuitry and vice versa, and the immune system affects the humoral system. So as you see, when we talk about heart-brain relationship, it is absolutely a lot more complex than just a pump and a clot. And I think the interesting thing, obviously, so you could imagine when somebody going to study the relationship between perfusion or vascular function and brain. As we study that relationship, we try to compartmentalize the relationship between those organs. Yet every other, I would say, category is ignored, and it's not ignored on purpose, obviously. As we all know, it's very difficult to study the whole. But having said that, when we study segments and not account for other components, the knowledge is incomplete. And I think at least understanding that relationship, we can put things in perspective as we look at the heart-brain relationship. So we're going to begin by looking at the pump and vascular function and how it connects the heart and the brain. Obviously, this is sort of just a very simple anatomic description here. You see the aorta down here, you see the subclavian arteries, you see the carotid arteries to the anterior cerebral circulation, you see the vertebral arteries back, and here on the right, intracerebral vasculature. Obviously, I'm not going to go through all the detail. And again, here, I would say that the system that's often ignored, at least from that relationship, is the lymphatic and venous system. I'm not going to talk about the lymphatic system. There's a lot, I think Dr. Arnold and other doing work with lymphatics and brain trauma, but the venous system have been literally ignored and not really investigated sufficiently as to how the venous system in the brain influenced by the heart and what sort of pathologies that cause. So I'm going to go quickly over this just to put things in perspective. When we talk about the relationship between the heart and the brain, we need to look really close in the brain to understand how blood vessels and brain parenchyma interact. So as you see here, right, so this is a pale artery, right? This could be a branch of the middle cerebral artery, anterior cerebral artery, right? So this artery is covered by smooth muscle cells and endothelium, and we'll see that later. It bifurcates down to penetrating arterioles, and those arterioles become capillaries. As we see, the neurons, the interneurons and astrocytes have receptors that connect to the surface of the arteries. Also, there's pericytes that connect to the capillaries and the penetrating arterioles. So the relationship, obviously, between brain parenchyma, brain cells, and capillaries, very intimate. Now, let's think when the heart is involved, clearly those blood vessels are connected to the heart. So abnormalities in the heart will cause abnormalities in blood flow. But also abnormalities in the heart, as you will see later, will cause neurosignaling between the cardiac neurons and the brain neurons, using a totally different pathway, not through the blood vessels. And that will impact also brain function through many, many other ways. And I think so, as we go forward, you're gonna notice I'm always talking about different things just to keep, again, the whole in perspective. Obviously, when we talk about interaction between the vascular system, the heart, and the brain, we have to talk about the blood-brain barrier. So the blood-brain barrier has been talked about and investigated for years. And I think the perception was, or maybe is sometime, that it's a really absolute barrier. It just doesn't allow anything to get in. Obviously, in reality, that's not right. It allows certain things not to get in and other things to get in. And obviously, there's transporter systems, independent and dependent and independent. There are, interestingly, in the blood-brain barrier, there's not enough adhesion molecules. And that's by design, because the blood-brain barrier does not allow or do want to try to prevent cells from getting into the brain, specifically immune cells, because obviously the brain have its own immune cells, right? It has the astrocytes, the microglia, the dendrocyte, etc. And I think that's by design. It prevents macrophages and other immune cells from entering the brain under normal conditions. The term neurovascular coupling, and obviously this is important as we talk about inflammation or functional MRI. So neurovascular coupling means that when there's neural circuitry activity in the brain, that would require increase in blood flow. So hence it's neurovascular coupling, and that's obviously the basis for functional brain MRI. I don't want to go obviously through the mechanisms and receptors, but just to say when we talk about functional MRI, we're talking about neurovascular coupling. And I think, as we will see later, when we do functional MRI for psychiatric disorders or other tasks, what often we don't look at is what's happening in the heart, because we're going to see later that cardiac function could directly impact neurovascular coupling, irrespective of what the brain is doing. So this piece of information is relevant to many areas of study. Another really important thing that's kind of, maybe beyond the scope of this discussion, but relevant, that there's more emerging research to suggest that the endothelium in the blood vessels in the brain may play a role in neural signal transmission, in a sense that when we think about neurocircuitry, often people assume that the transmission happens only through the neurons and synapses, which is, I'm sure it's probably the primary mode. But there is some work that suggests that this hyperpolarization, because neurons are in contact with the blood vessels, that endothelium in the brain may play a role in conducting neurocircuitry. Hence, again, vascular disease could impact brain function. Now, moving to another area, obviously, again, inside the brain, relevant to the neurovascular coupling, is how pulsatile pressure cause injury in the brain, right? And here we have, again, a group of investigators doing elastography and MR and all. So again, there's work that clearly illustrate that even changes in pulse pressure, and pulse pressure, for those who are not familiar, when you have, it's the difference between systolic blood pressure and diastolic blood pressure. And pulse pressure increases with age and some other comorbidities, but specifically result from stiffening of the aorta and carotid and other cerebral vessels. Again, without having to go through all the details, molecular mechanisms, and how this happened, increases pulse pressure can impact brain parenchyma and all brain cells. And again, there's more work, few studies with references, if some would like to go into the detail of that. This is kind of just illustrate the normal side of the brain, not exposed to normal pulse pressure versus another side of the brain exposed to higher pulse pressure, and what are the postulated mechanisms that pulse pressure mechanically cause cerebral damage. Now I'm going to move on outside the brain. I'm going to move to the heart and look at what is the evidence that cardiac disease can affect neurovascular coupling and cerebral autoregulation. And this is important because if we want to do brain inflammation or functional MRI study, we need to make sure to look at what's happening with the heart. So atrial fibrillation is a very common condition where the atria in the heart fibrillate instead of beating rhythmically. And it's a very common problem, and it's increasing with age. So this study specifically looked at the capacity of the posterior cerebral artery, specifically vasodilation response to neurostimulation in patients with AFib. And clearly, with patient with AFib, have dampened neurovascular coupling and cerebral autoregulation similar to HT or hypertension compared to healthy volunteers, right? So this is just a sample. If the patient have atrial fibrillation, their neurovascular coupling will be affected irrespective of what brain disease they may or may not have. Second issue, which is I think find this interesting because really it's severe, under-investigated, is that cerebral venous congestion, meaning increasing venous pressure, and that happens frequently in patients with heart failure. That promotes blood-brain barrier disruption and neuroinflammation, as well as impaired cognitive function in mice. And this sort of shows a sham control mice versus jugular venous ligation to induce increased cerebral venous pressure. And here shows the mice trying to get into areas, and a lot of errors here when there's venous congestion versus no errors with sham, right? So again, venous congestion is, I would say, a common standard physical sign and symptom in patients with heart failure. So patients with heart failure, then a lot of them may have blood-brain disruption chronically and therefore may be exposed to neuroinflammation. And this sort of illustrates that relationship between cerebral venous congestion and neuroinflammation. I don't want to go through the details. So now all this discussion was about the pump and vascular function. So as you see, it's really critical, it's really important, but not just in terms of pump power and clots. There's many other, I would say, factors how this pump can impact directly neurovascular coupling and neuroinflammation. So second, we're gonna move to the humeral space. So let's focus on just core concept related to the heart. So the heart is not only a pump, the heart does produce hormones. The two most sort of famous hormones are atrial natriuretic peptide and brain-like natriuretic peptides. Now those peptides are also produced in the brain. And those peptides, when they are excreted from the heart in response to mechanical alterations. And when they're excreted, those hormones go to the brain. And again, I'm not going to go into details how they kind of stimulate corticotropin. They also go to the kidney and cause systemic changes. Interestingly, the brain natriuretic peptide is obviously also produced in the brain. It does have a protected impact on the heart, and there's cardiac receptors where BTMP attached to, and actually it's protective in acute injury. So this is sort of a self-defense mechanism. So this is sort of the humeral or the cardiac brain humeral relationship. Another relationship that's extremely important. So I'm showing this diagram. This is taken from a paper looking at the impact of stress on neurohumeral system. So stress, impact the hypothalamus, the paraventricular nucleus, cells, and then this nucleus produce corticotropin releasing hormone, vasopressin, that stimulate the pituitary, secretes ACTH, adrenal gland, glucocorticoids, and again, a negative feedback loop that affect other organs as well as the brain. The piece of knowledge that's important for us to recognize that the heart, when there's injury, like myocardial infarction, there's neurosignaling, right? We talked about the pump function, the neurosignaling that also the neurosignals from the heart goes through the stellate ganglia to the medulla oblongata, to the insular cortex, to the amygdala and the hypothalamus. And there's studies illustrating that through retroviral studies. So whatever cascade we have in stress, that cascade is being implicated when there's myocardial injury. So the role of neurohumoral hormones or cardiac neurohormones is fundamental and integrated into the neurocircuitry, as well as the pump, as well as neuroinflammation. Third, we go to the neurocircuitry. So that's the neurocircuitry. Now here, obviously, please don't get scared, because when I see this, I get scared, right? Obviously, the relationship between the heart, the aorta, carotid blood vessels, and the stellate ganglia, thoracic ganglia, cranial nerves. So this is just a diagram to illustrate the complexity of neurocircuitry, neuroconductivity between the heart, the intrathoracic vessels, the spinal cord, and the brain. To begin that discussion, first we need to look closer at the heart. So the heart, again, is not only a pump. There is about 50 to 90,000 neurons in the heart. Some call it the little brain. And those are dots, are the neurons. The neurons are or exist in the epicardial fat around the heart, primarily around the atria, a little bit between the atrial and the ventricle. And there's been a lot of studies trying to analyze or look at the cellular and molecular sort of characteristics of those cells. Recently, and this is from the UCLA group, they've done clarity and other techniques to actually visualize the intrinsic cardiac nervous system neural fibers. And what you see here are actual neural fibers connecting cardiac neurons. This is the extent I'm going to discuss this. This is a simpler diagram. And this is, obviously I don't really mean that, just express the complexity. So this really gives name to this connection. Let's look on the right side, right? This diagram, we're going to look at the heart in terms of the receptors. We're going to look at the intrinsic cardiac nervous system. What side of neurons does it have? We're going to look at the extracardiac but intrathoracic ganglia, that obviously it's the traffic lights between the heart and the brain. And then you have spinal cord, brainstem, cortex, and then subcortical region, including the limbic system. We go back to the heart, obviously, we all know there's sympathetic, parasympathetic receptors, right? But also more importantly, there are sensory receptors. The sensory receptors, there are baroreceptors, chemoreceptors. So if there's a heart attack, it's going to induce mechanical changes. It's going to induce chemicals. Those changes will be transmitted across directly through the intrathoracic ganglia, again, to the medulla oblongata, to the cortex, to the amygdala and hypothalamus and hippocampus, right? So there is a well-defined neural pathway between the heart when there's myocardial injury and the nervous system. Now, obviously, in terms of those neurons we spoke about, they're either parasympathetic, sympathetic, afferent neurons that are sensory neurons, and then there's sort of neurons that play a connecting roles between all those neurons that are really not well characterized. And again, in the heart, really, when they say sympathetic and parasympathetic, is not that obsolete. There are some neurons that have both sympathetic and parasympathetic function and connections. So again, the purpose of this just really to have a broader understanding that the heart and brain connection is not purely and simply sympathetic and parasympathetic. That's obviously very important and very basic. There's lots more going on that could impact more limbic system function. I didn't even talk about locus coeruleus in the medulla. The locus coeruleus in the medulla is the sort of epinephrine center in the brain, and it has connections all over the brain. The heart directly neurologically connects with the locus coeruleus. So you could imagine when there's a heart attack, the signals go to the locus coeruleus, it activates that epinephrine center, and then it activates everything else in the brain. So, and obviously epinephrine activates immunity. So I'm not here kind of off topic. I'm just doing all this to show you that inflammation, not as simple as just immune cells. There's work that was actually done looking at these neurons in the heart and to see what happened to these neurons if there's a heart attack. So on the left, A, normal cardiac neurons, B, abnormal cardiac neurons in heart attacks. They get bigger, they have inclusion. So do we know how these neurons begin to signal? Obviously, we don't. There's lots of information that we don't know, but we could imagine that with changes in neurons, their function going to change and their signaling going to change. This is a piece of information. Again, this is a separate study, just looking and documenting that increased amygdala activity is independently and robustly predicts cardiovascular events. How? Stress. Again, amygdala, again, we talked about the whole mechanism of the stress. So amygdala increases cardiac events. But also, this is a study showing that induced ischemic heart failure in rats, just inducing MI in rats, will cause structural changes in microglia and astrocytes in the amygdala and the paraventricular nucleus. Right? So the pathway between the amygdala and the paraventricular nucleus, hypothalamus, between the heart and those structures and microglia is again connected through neural mechanisms as well as inflammatory mechanisms. And this is the work through the locus coeruleus, the epinephrine system, that also there are, I would say, more very much foundational basic studies and limited number of studies. And some even attempted to use 3 Tesla and 7 Tesla MRI, this is on the right, to visualize the locus coeruleus. It's very small. I spoke to MRI experts and people don't feel necessarily that, this is going to be the way to look at it because it's very small, but the work, at least some people are trying. So the purpose of just to again allude to the structure and that its importance between heart and brain connection. Number 4, right? Now we're going to go to the immune system. So myocardial infarction induces cardiac inflammation, right? This is a well-known, established phenomenon, right? There's no kind of controversy there. If there's a myocardial infarction and injury, that induces inflammation. The more important work that goes a little bit into depth is to understand that inflammation. So when a myocyte dies or releases cytokines, hormones, stimulates the immune system and the cardiac fibroblast. And first, you have a pro-inflammatory phase where there's M1 macrophages and lymphocytes, CD8 and B lymphocytes that cause bad inflammation, right? With interleukin 6, tumor necrosis alpha, etc. Under normal condition, this phase stops and evolves to the anti-inflammatory condition where you have the M2 macrophages, the CD8, the good immune cells that try to heal. So this is sort of a well-established process in myocardial infarction. Now one could ask, is there a situation where the pro-inflammatory phase continues and does not become anti-inflammatory? Theoretically, it's possible. There's some disease states may suggest that, but we don't have really, there's a lot of work that needs to be done to understand. But I think this is really important, this hypothesis, because only 1 out of 3 MI patients have depression and brain inflammation. So theoretically, one could say, maybe those 1 out of 3, those had just inflammation that got out of control in the heart that led to unchecked inflammation in the brain. We don't know that, but this is kind of a question really to ask. There's more detail again to go on the what's exactly involved in the pro-inflammation phase. I don't want to go into that. And what's involved in the anti-inflammation phase. Again, it's a good immune system, not so good, but this is to simplicity, or good cells and bad cells. The bad cells begin the process, the good cells come and going to close the loop, but that loop may not close occasionally. So when there's inflammation in the heart, right, it's also worked out very well, and there's many studies to say that also there's systemic inflammation. These cells and cytokines gets excreted in the bloodstream, stimulates the bone marrow, stimulates the spleen, the thymus, and all these organs begin to work and produce lymphocytes, that's killer lymphocytes, etc., and cytokines. So you have a full-blown systemic inflammation within about 3 days of acute myocardial infarction. Next, I'm going to go to the same study. When you have the systemic inflammation, then you have neuroinflammation. And this is one of the studies, again, that specifically looked at the microglia and astrocytes in the brain and the amygdala, and that those are activated when there's systemic inflammation. So now I'm going to move to kind of a little bit. So I provided sort of the background, the holistic view. I want to move to the studies, or a few of the studies that experimentally tried to look at the relationship between myocardial infarction and brain inflammation. We know there is myocardial infarction, myocardial inflammation. We talked about that. We know there's brain inflammation from other causes, but now we're talking about does MI cause brain inflammation? So in this study, the investigators looked at about 52 mice, about 9 sham, and 43 they occluded the coronary arteries. Then what they did, they used PET, and they used chlorofluorine, carbon fluoride 18 GD180. This is kind of used in PET scanning, and they they tagged the TSPO protein in mitochondria, right? So PET scanning on those mice. Then they used the same on patients, but only 3 patients. So they have 9 control, and this is, I think, 1, 5, or 3 Tesla MRI, 3 patients. So they used PET scanning, and they're tagging the TSPO, which is a protein that's active in the cellular mitochondria. This is what they found. This is in mice, right? So A, here's the heart, B, in the brain, and this is for the patients, right? So when you look at the heart, the first row here is system MB. This is a standard nuclear cardiac stress test. As you see, there's defect up here. We call it anterolaterally where the arrow is. So this defect means there's no blood flow here from the MI. The second line here is the PET scanning of the same cross-section looking at the TSPO activity. And this lights up. That means the labeled agent showed up exactly in the area of the infarct, right? If you look at those patients, what happened here, this is MRI and PET, but what they did, they co-registered the PET on the MRI, right? They did not use MRI to image inflammation. They used PET, and then they superimposed the PET on MRI and localized the areas were light up in the brain, specifically in the frontal, parietal lobe, and some in the subcortical region. So that's 3 patients in this study. There was no study of behavior or MRI only to image inflammation. Now, obviously, this is sort of in the mice, right? So also they've shown that when you have acute cardiac inflammation, you have acute brain inflammation, and that over 8 weeks, the inflammation subsides. But then when the heartbeat fails and becomes chronic left ventricular failure, the inflammation lights up again, and potentially there's 8 weeks, obviously is not 10 years, but in mice, they're calling that chronic. So this is one study that really looked in detail, and a very good study using PET, look at how the process works in mice and only in 3 humans. Now I'm going to go back to the first diagram I've shown in the beginning about how stress caused myocardial damage, right? We reviewed the autonomic dysfunction and the neurocircuitry connectivity, the HPA axis, reviewed the immuno sort of dysregulation. And again, I could use this same diagram to say if you have myocardial infarction, just reverse the arrows. And that would cause brain damage. And hence, stress models can be very good myocardial model. And I think that's would take us when I connected with Dr. McKim and all how this came about. So let's kind of just review what do we know and what we don't know. So what do we know so far? That 1/3 of patients with heart attacks are more prone to depression. So that's clear from individual and epidemiologic observation. There's also a reasonable number of or amount of experimental evidence, but limited human observations that support the concept that heart attacks can cause systemic and brain inflammation. So what do we don't know? Does myocardial infarction induce brain inflammation cause depression, right? We talked about the association. Association doesn't mean causality. There's some studies, I don't have it here, that looked at that and tried to associate the two, but the studies I would say were lacking in methodology. And obviously there's no time to go over those specific things. 2, does this causal relationship exist in every subject, right? And if not, why not? And this is really, really important, right? Because if 2/3 of patients with heart attacks don't have depression and 1/3 does, why is that, right? Obviously, answering that is important from a clinical perspective. If we can't answer that, we can't predict who to test and who to treat. Third question, what are the culprit brain regions that are impacted with inflammation? Now, we've seen some studies pointing to the amygdala, to the hypothalamus, to the frontal lobe. A lot of those studies did not actually look at the whole brain. There were pre-selected sections, which is a specific deficiency in studies that need to be addressed. And that's why we're putting the question here. 4, can we use high-powered MRI, which is 9.4 Tesla in mice, 7 Tesla in humans, to image brain inflammation? This is clinically extremely important. As we'll see later, there's some MRI studies trying to image inflammation in the brain with 1.5 and 3 Tesla. And we'll see that then why 7 Tesla clearly could have a huge advantage over those in imaging inflammation. And last, obviously, is how can we interrupt this causal relationship between MI and depression if we want to get this therapy to the bedside? So let's talk about MRI imaging for inflammation, heart and brain. There's a problem, right? MRI detects edema. Even 7 Tesla, it only detects edema. It cannot detect inflammation. So what are we going to do to actually see inflammation? Luckily, right, we have something called ferritin or ferromoxetol, which is essentially, it's a sort of paramagnetic iron oxide particles. Right? And they're been approved by the FDA to treat patients who have anemia from chronic kidney disease. That's the on-label indication. Over the years, people figured out that this agent can be used as a contrast agent in MRI. And the very dominant use for the agent is vascular imaging. So some centers use ferromoxetol instead of gadolinium to image the vasculature, specifically in patients with renal failure who you don't want to give gadolinium to. Luckily, again, this same agent is not only a contrast agent. It's recognized by pro-inflammatory and anti-inflammatory macrophages. So macrophages, when there's ferroxymetol in the blood, it binds to the macrophages. Okay, so that opens the door to us using this agent to identify inflammation. So ferritin, as I said before, it's a negatively charged carboxymethyl dextran-coated ultra-small supramagnetic iron oxide nanoparticle. Oh my God, I don't know how I said that. This is kind of a lot of words. Okay. But it's clinically approved as an iron supplement. And as we've discussed, it's used as a contrast agent. Now, so let's look at some of the studies that looked at the use of SPIO in the heart first. And this study is about 12 years old. So those investigators actually used mice and did experimental heart transplantation in mice, transplanted heart. Then they wanted to know if there's rejection, right? And obviously in rejection, you have macrophages involved. So they injected the ferroxymetol, and they were able to track the macrophages in rat using MRI. So if you look at this MRI, if you look here, for example, on the right side, right, it's kind of a smooth muscle. If you look here in the box, you see holes in the heart. Those holes are hypointensity images from the iron. So the iron reduces T2 and cause hypointense signals. And by histology, those are the dark material are the iron oxide. So then that means we have, if we give this agent in the heart and there's rejection or inflammation, we expect to see holes in the heart muscle. A recent study just published 3 years ago, actually it was more sophisticated, right? And I don't want to go through the detail. So this is kind of patients also. This is actual patients who have heart attacks. So they did cardiac MRI first, then they infused SPIO, and they did it at multiple times, right? And really it's a good study to look at what is the perfect timing to image cardiac inflammation. So this is not heart brain. This is purely the heart. So I'm going to show you here some images. Now you say those are humans. How come we have histology images? Well, I mean, those patients didn't die. The investigators actually, some of them, the patient went to surgery, to cardiac surgery, and in cardiac surgery, they actually took biopsies from the infarct area. So this is, we got the slide. So let's look at 3 rows here. So this is hematoxin iosine staining, right? This pink area is normal myocardium. This pale is infarcted myocardium. And as you look at the dark dots, this is inflammatory cells. So this is HE staining. We go to the Prussian blue staining, right? Again, a box here in the infarcted myocardium. And if you go to 20 to 50 magnification, you see the bluish iron in macrophages, right? So this is acute myocardial infarction, and they were given Ferahem, and then you see the Ferahem in macrophages in the infarcted myocardium. And then you go with the CD68 staining to see the macrophages and the Ferahem inside the macrophages. So this is just an excellent study that showed that if you give Ferahem acute MI, you can expect at 3 days to see cardiac inflammation. Now, obviously, this study didn't say, well, was there any difference in severity of inflammation between the patient? Like we said, that's very relevant. Are there any predictors, et cetera? But it's a very, very good study looking at this issue of cardiac inflammation. And here, and I'm going to walk you through this because really it's important to understand because it's relevant to how we image inflammation with cardiac MRI. So let's begin with the images 1A, 2A, 3A on the left side. So this is cross-sectional cardiac MRI images with gadolinium, right? This is not Ferahem. As you see here on the top, gadolinium, there's a scar here. You see there's hypercontrast. This is septal wall. Here, a second patient, lateral wall. Here, another patient, inferior wall. So let's go to the up here and look at the septum of this patient. The R2 map is T2 star cardiac MRI map because Ferahem shortens T2. So this is a specific cardiac MRI sequence to image and map inflammation. So at the septum, you see it's a blue. The normal should be green, right? So this is basically how this would look in inflammation. And if you go and use a T2 map is a standard cardiac MRI map when you use gadolinium and shows only edema. So the T2 shows edema here. If you see early on, dark is normal, light is edema early on. So this is an illustration that those investigators shown that with Ferahem infusion, there are cardiac MRI sequences where you could detect inflammation in humans. This is again 1.5 or 3 Tesla. So we talked about the use of Ferahem in imaging cardiac inflammation. So let's talk about the use of Ferahem to image neuroinflammation. So this kind of study shows, at least in diagram, when you give Ferahem, what is the relationship between macrophages and Ferahem? There's 3 theories. One theory is that this is the blood vessel. If you give Ferahem, the macrophages sort of phagocyte Ferahem, eats Ferahem, and then the blood-brain barrier is broken by cytokines, and those phagocytes gets into the brain. This is the Trojan horse mechanism. Another theory says the Ferahem, those dots in the blood here, they directly go through to the brain. The third says the Ferahem goes to the brain, and then the macrophages in the brain eats the Ferahem. The correct theory, or so the dominating theory, is the first one. Macrophages binds to Ferahem in the blood and moves to the brain. And this study shows that, right? This is my study. Again, the first, they induce inflammation with LPS, not with myocardial infarction. And then they gave Ferahem. In those 2 other cohorts, they depleted macrophages, then they could not see signal. In the third study, they also find a way to block the receptors on macrophages, and they could not see Ferahem. So Ferahem gets into the brain because macrophages in the periphery swallows the agent and takes it to the brain. And again, this is another study sort of documenting control sort of, and again, this inflammation, not MI, this is LPS, right? So this is purely neuroinflammation, have nothing to do with MI. This is just to show that Farahem can be used to image brain with neuroinflammation. This is control at different locations, and this is the neuroinflammation. You see here two things. You see in the ventricle, there's the hypointensity signal is much higher compared to control. And then you see the dark dots, right? And again, histologic evaluation showing the iron oxide in the same location. So again, here we could imagine then how would 9.4 Tesla and 7 Tesla, would it be better than this to show us those abnormalities induced by Farahem? So this is sort of the background, right? You know, the question is, there's known facts about the issue, and there's a lot of unknowns. So how do we investigate those questions at CIMed, University of Illinois, and Carle, right? From bedside to bench and back, and obviously, right? So again, we kind of plan to do bench investigation and clinical. And frankly, the clinical came first because we could not, in the beginning, identify a basic scientists in campus who have expertise in this area, not because there aren't any, because I just could not find any. So we'll tell that story. So the conundrum of translational research, and we talk about it every day, right? Basic scientists, engineers looking for clinicians, they can't find them. Clinicians looking for basic scientists, they can't find them. Well, luckily, kind of, we crossed at least one of the bridges. So the first study about a year and a half ago we start talking about is to look at whether we could use 7 Tesla, a brain MRI, to image the brain of patients who have myocardial infarction. So similar to a study that was done before, I showed you only 3 patients, right? In that study, they used regular sort of PET scanning, not even MRI. And obviously, the Clinical Research Institute, the Beckman Institute, CIMed, and we have now 3 or 4 scientists interested in the topic and experts in the topic. And we're going to, in the next month or 2, begin how to move forward this protocol. This is kind of be the team, and I think the team also will continue to expand. Dr. Whiting, Damon, Sutton, and others. So in this pilot study, we're going to get 20 patients who have completed their myocardial infarction. Sometimes patients have an MI at home. They don't come to the hospital until a day or 2. That's not a good thing, but that happens. So those are the patients that we're going to try to enroll in the study, that they have completed MI. First, we're going to do 3 Tesla cardiac MRI at day 3 to image the extent of inflammation. And the extent is really important because we're going to try to see, is there variance in the extent of inflammation between patients? Then in a week after MI, we're going to do 7 Tesla MRI with Farahem to look at the presence, extent, and localization of inflammation. And then we're going to try, again, this is only 20 patients, going to be preliminary and give us hints. Do we see any sort of even numeric correlation? Obviously, the third is going to be very difficult with a small number of patients, but again, looking for hints. So the sequence, again, day 3, it's going to be 3 Tesla cardiac MRI. Day 7, 7 Tesla brain MRI. The question is really the chronic brain MRI, when to do it, right? So for this to be relevant, right, in terms of for patient impact, if we see something at 1 year, that means, gosh, this really, there's something that could cause depression. If we see something only at 1 month, well, we don't know what's going to happen at 1 year, so it may not be relevant. So we're still discussing at really when to get the MRI. I think 1 year is better if we could bring these patients back, and that's kind of the ideal. So that's sort of this project. I would say it's close to IRB approval. We're going to still are meeting, or we're going to meet to determine the MRI sequences. Obviously, I think because we haven't used, I guess not we, nobody have used 7 Tesla MRI with Farahem or for inflammation, right? You know, so I think we have enough data out there, I think, for us to begin to maybe consider using the sequences that were used in maybe 3 Tesla MRI. And that's the discussion that we need to have to finalize the protocol. So obviously, in addition to the MRI, we're gonna do echo, EKG, some blood testing looking at white count, CRP, cytokines at different time point, just to understand also whether there's a variation in cytokines and other manifestations between those patients. Moving on, that was the sort of clinical translational protocol. Now, I think the basic science protocol is really much more difficult. It took me sort of a year and a half or two to find Dr. McKim in Animal Sciences, who's interestingly, I had to look and search the literature. I found that he's working on stress and neuroinflammation, right? Not heart and neuroinflammation. But we've already seen that stress and neuroinflammation is really have a lot of common component with heart and neuroinflammation. So I called him, he was interested. Then we talked to Dr. Dubracki and our postdoc fellow Marcin, because they have the expertise in inducing MI in mice. And we sort of discussed initiating the sort of bench protocol looking at mice brain inflammation, heart to brain inflammation, but also the unique work of Dr. McKim that he studies mice behavior. Because obviously we already know that heart inflammation causes brain inflammation. There's really several studies that document that. So the unique part here in this specific study, two things. Can we use 9.4 Tesla MRI to image cardiac and neuroinflammation using Farahem, right? This is unique component. Number two, can we evaluate behavior in mice as a result of infarction and brain inflammation to see if there's a brain behavior in a more comprehensive way? Right, so this is going to be the purpose of this. Again, we're going to use 9.4 Tesla cardiac MRI to image the heart, which have not really been done in the past, because obviously we know that the mice goes at 600 beats per minute, right? And we're talking to the physicists at Beckman to do some studies, and we may have to change a little bit the bed of the mice to be able to use the brain coil as a cardiac coil. So there's some work need to be done there. But then also use the 9.4 Tesla for the brain, and then ask the same questions about correlation and about mice behavior in its relation there. And this is sort of the timeline. Courtesy of Dr. McKim. So this is what his lab gonna do after inducing the MI and having the brain and heart MRI. Activity of the mice, looking at anhedonia and depressive-like behavior using the standard metrics that he used in his lab, and looking at anxiety-like behaviors. He's also going to do biologic analysis, looking at cytokines, cytometry, immunohistochemistry, and try to do a network analysis to understand how the MRI behavior biologic measures relate and correlate in terms of brain inflammation impact on behavior. So hopefully, obviously the purpose here is to identify specific culprits that we could, again, translate to the clinic. Number one. Number two, really, this, I think both the human study and the bench study, we're going to enable us to get enough information. Can SPEO MRI, that's high-end, high-powered MRI, used to image brain and heart inflammation, and can it be used as an endpoint for early human trials? Last, this is basically we're in the beginning of T0, I would say T1 work. And I think, obviously, this took a long time even to begin talking about the protocol, because it was difficult to identify collaborators and team, right, which goes to how we build translational research. But we're lucky to have a nucleus of team to begin this work, and hopefully in the next year or so, we'll share more. Thank you.
Okay, Issam, thank you so much for a really clear and thoughtful lecture on this frontier space. And I'm excited that we've got questions in the chat. If you don't mind, I'll just call people out who could just ask you directly, if that's okay. So
absolutely.
Dr. Olivero, could you like to go ahead and ask your question?
Yeah, I typed the question there, but basically the question is, in patients with the MI that have...
so sorry, I cannot hear at all. It's a very, very faint. I cannot hear Dr. Olivero at all.
Can you just read my question then?
Let me see. Okay, let me go to the chat. Okay, let me go, Dr. Olivero. Okay, are there any autopsy results in patients who have died after MI that have documented inflammation in the brain? The answer is no. And this would seem very obvious, and actually I've thought about it, about a year ago, but we don't do, I mean, we don't have that sort of a infrastructure capacity at Carle. And I spoke to some external collaborators about it. So, but it has not been done. And clearly, I think this is something that doing that, especially in patients with sort of clear cardiac ischemic injury, especially severe, and those patients unfortunately sometimes do die, that would be definitely a piece of information that would add a lot, but it has not been done. Could I speak to the second question? So I'm going to talk, so the second coming from Anant. It seems like a large portion of the connection between the heart and the brain are humoral and endocrine paracrine in nature. Markers of inflammation, different molecules affecting neuroendothelial cells, etc. What technological advances would we need to better appreciate the electrical circuit-based connection between the heart and the brain? Better electrodes, improved fast DTI MRI. That's a great question, right? So I think part of the lack of progress, let me just say this again, really, part of the lack of progress in this field is that we do not have the tools to do the following. So the cardiac intrinsic neurosystem obviously exists. I could tell you that if you talk to 100 cardiologists about the cardiac internal nervous system, the overwhelming majority will not know what that is. People would talk about the AV node, the SA node, the conduction system. But if you say neurons, that's unknown because this area have not got to the clinical area, and there's very few cardiologists investigating. Now, if we're going to ask the question, those cardiac neurons, how do they behave in health and disease? How do they stimulate in the brain? Unknown, right? And interestingly, there's some work being done by Professor Elizabeth Hillman in Columbia, not related to the heart, but she came up with an interestingly mouse model where she could do brain calcium imaging in response to stress. So you put the mice, right? You stress the mice, and I'm not familiar with the technology, and you could see the brain lighting in certain areas. Now, if we could get that model and stress or injure the heart, then we could see some of that in mice, right? So I think to answer your question, there's some technology somewhere in the US that people have technology that probably can be used to study heart-brain connection more thoroughly. And this is obviously, because it's not really there yet, it's a huge area that would be worthwhile for very smart people to look into. Okay, so going question number 3, Muhammad Amir. Any thoughts on how this cardio-neural relation in post-human heart transplant patients is affected reported? Yes, it's not, unfortunately, right? So in autopsy studies, there've been a lot of studies looking at autopsy of the cardiac internal intrinsic nervous system in isolation. There's obviously lots of study on brain inflammation in Alzheimer, right? And in other multiple sclerosis. They have not been, here we're talking about transplant, even transplant, it has not been. And actually I've discussed that with the Northwestern transplant team over a year ago. We were actually entertaining doing that study instead of the MI for 7 Tesla, but after discussion decided to do the MI. But certainly heart transplant patients would be very interesting to do a similar study on them with 7 Tesla and see how cardiac and brain inflammation unfold there. So going forward, Jessica by Barth, I know she's very interested in the field. There's evidence that pediatric patients that have been in cardiac PICU have cognitive decline. Is there a possibility of looking at prior PED patients to look for chronic brain inflammation? Absolutely, right? So I think, frankly, unfortunately for those babies, but that could be extremely insightful, right? Because if the cause of a disease in those infants was purely cardiac, right? There's no other known disease. And you evaluate them acutely, subacutely, and long-term, and can compare them to control. That certainly would be extremely insightful. Going forward, this is a direct message. Okay, so I'm gonna skip that and get back later, right? It's not for the group. Okay. I'll discuss it maybe at the end. So Neil, I guess, wonderful. So this is a compliment. Okay, so you're asking about, okay.
Well deserved, well deserved.
Well deserved, yeah. So for example, traumatic brain injury, stroke, epilepsy inducing heart disorders down the lane. So I would say absolutely. And again, and there's actually initial more epidemiologic work showing, for example, if patients have insular stroke in the cortical insula, or epilepsy, that those patients may be susceptible for arrhythmia, because the insula is sort of the highest cortical connection to the brain nervous network, right? And the insula also, right or left, have differential impact on the sympathetic parasympathetic system. So this is something in our, right, we could do it here, right? And I think, again, because of the number of things that everybody want to do and this limited number of people, but this is absolutely something, every single entity, it can be studied at U of I and Carle, because there's absolutely foundational work and some epidemiologic work that support that this connection exists. This is from Sheba, sorry. So the compliment was by Neil, sorry. This is, okay. This is from Dr. Sheba. So yes, so I was thinking about you, Dr. Sheba. You're on my calendar, right, before you reaching out to me because of this. So yes, we'll talk. I think the last was, I think was direct message. Starting my postdoc, planning and behavioral sequence analysis would be interesting to apply this type of analysis to quantify behavioral changes. Absolutely, right? The more detail, because we all know behavior is complex and many things affect it. So the more specificity, right? Depression is depression, but it's pretty broad. The more specificity we have at every level, I think, the more insights we could get from this sort of investigation. So that's, I think, the end of the chat room messages.
Okay, Issam, thank you so much. I had one more follow-up. So you talked about iron as a marker of the inflammation. I'm curious to hear your thoughts on the potential role of iron as a transducer of the inflammation into damage. So as you're probably aware, there's this hypothesis, the rusty brain hypothesis, where increasing iron content that results from inflammation may be a driver of oxidative stress that causes cognitive decline. And mechanistically, the idea that inflammation causes a decrease in the protein ferroportin, which is the exit valve for iron from macrophages. So I was wondering if you've thought about this, or if there's kind of insights on how those might all be connected, and how we might kind of think about trying to interrogate that with the power of the MRI to see whether, remediating that iron buildup could actually, remediate the neurocognitive deficit, which would be a really exciting question to try to get into. So I was just kind of wondering your thoughts on that whole space and how you think we might leverage the MRI in that context.
Yeah, so it's interesting, Mario, that when I met you first, you told me that, this is kind of how you operate and think, right? You look at molecules in the body and how you use them to the advantage of humanity. And I think this obviously, right, this falls in the same direction. So I think clearly now, let me just kind of share a few relevant facts, right? So we all know, obviously, that if you have hemochromatosis, right, that disease entity where you have cardiac infiltration, liver infiltration, brain, we know, so we have a pathologic entity that can be used to support your idea that, yes, obviously, iron, when it goes up, it's bad on multiple levels, number one. Number two, with this agent, with the Ferrahem, there's a clear also guidelines for use. You could use Ferrahem only in terms of as a contrast agent in study twice a month. Why? Because if you use it more than that, you could get a little bit overload, not overload hemochromatosis overload, but overload in terms of iron deposits. So going back, I think the interesting thing would be how to begin to study this is actually to look at patients with hemochromatosis, right? Patients who actually do have excess iron, and maybe begin to do some work with brain MRI, 7 Tesla. I don't think you need, the question really is, you don't need Ferrahem. I think if there's excess iron, but I don't know if the iron hemoglobin associates would bind to macrophages like the SPEAL. So I think clearly it's absolutely I think very meaningful translational concept. The question is, right, is where to begin and how, number one, which patients and which model you would begin to investigate. But clearly knowing iron that binds to macrophages, if it's synthetic, clearly you would think that if it's natural, it may be doing the same thing. But I don't know. I have not looked into that. But I think the concept is absolutely translational and it's worth pursuing.
Well, we have done a lot of studies with iron and other metals in the MRI, and there are actually many different forms of iron. With the contrast agents, they are actually not, simple little iron deposits. These are called supraparamagnetic. They have to be of a certain size before they actually can be easily detected with MRI. That's why they form a special formulation. And those also, because they're bigger, can be easily picked up by the macrophages. So this type of contrast agent to indicate inflammation is especially formulated and very different than the iron deposits that we're looking at. If you look at the natural iron deposits, you need a lot before they're detectable with MRI, and usually they are actually very late stage diseases. So that's why I don't believe looking at natural iron deposit is an easy way to go, even with 7 Tesla MRI. But using iron particles as designed by these contrast agents as a way of localizing macrophages is very feasible. Whether the localization of macrophages is the only way that you can detect inflammation with MRI is another story, right?
I agree.
And I would say there would be more than one way of detecting inflammation rather than just looking at macrophage localization.
So I agree with Dr. Lee. There's actually several papers that go over all those iron oxide-based nanoparticles. And in the US, interestingly, some of them were discontinued. I don't know why. So in the US, ferrohem is the dominant, but it's absolutely true. I think the other ways to detect inflammation, so with PET, obviously PET is sort of gold standard, and there's many ways. With cardiac MRI, that's another area, right? So I think clearly in the literature, there's no sequence that I've seen other than ferrohem. But the question, can one be developed? I guess that's always an open question with high-powered MRI.
Right. No, I think for sensitivity issues, I would go with PET, and PET fusion with MRI is easy to do. The brain doesn't move very much, so unlike the heart, you can easily fuse PET images with the brain, even though they're not co-localized in the same machine. There's have been done over and over and over again, and information detection using PET is relatively straightforward and very, very sensitive, and I would say that's probably the easiest way to go after inflammation in the brain.
So just to build on
yes. So sorry to comment. So the study I've shown in Germany is actually PET-based. And it's interesting, I was talking to an investigator in France, it's a she neuroradiologist. Interesting that they have actual now MRI PET, right? So it's obviously we're talking about research methodology, not necessarily clinical use. Eventually, clinically, you're gonna use the simplest, most cost-efficient way. But in terms of research, the more imaging modality we have, the more insight we'll get. Sorry, Marty, go ahead.
Oh, no, I didn't mean to. I was just actually going to add to what King had said. So agree, King, the nanoparticles have a higher signal to noise, no question about it. But there's actually, I think, some really interesting emerging evidence that there could be highly usable signal to noise in just the natural abundance. The work comes actually from Antonello Pietrangelo, who's he's a cardiologist and hematologist in Modena. And what he found was that in patients who have a ferroportin deficiency, and he actually identified this, it's called ferroportin disease. He discovered it in an Italian family with a mutation in the ferroportin gene. They have, very interestingly, a dominant negative mutation so that their ferroportin actually goes way down in their liver, and particularly in their Kupffer cells. So they get a natural buildup of iron in their liver, and he tracks it just the way Issam showed it, using just the T2 acceleration. So that you can actually see, he'll phlebotomize the patients, and over a course of 3 months, he actually watches the iron build up in their liver, and then he phlebotomizes them again, and it comes down, and then he watches it go up slowly over time. He's published these amazing papers, and actually the signal to noise is surprisingly good. There's also, in the context of transfusional hemosiderosis, iron buildup in the heart. And you can actually check that also by MRI. And this is, again, now a little bit more of an extreme situation, but it's still natural iron. So my point is, I wonder, and of course it's a testable hypothesis, there may be an untapped potential of using natural iron buildup in the brain, especially with a sensitive instrument like the 7T. And so we could be in a really exciting position to at least take a look. And we know which patients you'd want to look at, because those who have inflammation are thought to then, through the process of the kind of induced deficiency of ferroportin that is associated with the anemia of chronic disease or the anemia of inflammation, you kind of get a phenotype that's similar to the genetic deficiency of ferroportin. And so we could look for whether or not there's a demonstrable increase of iron in the brain just with natural iron. And if it's true, it would be a really cool marker for the inflammation.
But the concentration you need is pretty huge. I mean, you're looking at pretty extreme situations, right? People have done sensitivity studies, right? How much, how many milligrams of iron per cubic centimeters you need, right, for this with natural iron versus nanoparticle iron. All those studies have been done years ago, right? And you will find that the sensitivity is just not that high, even at pretty high field strength. And that's why most of the time when we detect natural iron, is in the pretty extreme situations, like you have mentioned.
So the other comment I want to add about the PET MRI, which is very specific for inflammation. The advantage of MRI, as you know, right? Let's say we want to image the heart. When you do cardiac MRI, you don't only see inflammation, right? You see everything in the heart. The same for the brain. If you have somebody you want to kind of have an abnormality, right? You do a PET, you see inflammation. You do a brain MRI, you see other. So I think there is a case to be made that even if this really reaches the bedside, that if cardiac or MRI is able to detect inflammation with reasonable accuracy and clinically meaningful, it would be advantageous to PET, because you would get in the same time other imaging elements that's important to decision making. So I think PET is a great research tool, but clinically I think MRI would have advantages.
No, I'm not talking about doing PET only, right? You're talking about doing PET and then an MRI and then fusing them, right? So you get the advantage of both without having a combined MRI and PET machine. Because at Carle, you already have a PET machine and you already have an MRI machine. So you can actually fuse those images and get those advantages without having, much difficulty fusing the images.
No, great idea. I just gonna need a little bit more funding. I'm gonna ask you. I'm just kidding. But yes, I think.
No. It's actually cheaper than using the 7T MRI probably, and the iron oxide.
But I agree. It's a very good. We have a PET CT, right, and we have 7 Tesla. So I think it's definitely a great infrastructure to do more.
Absolutely. Just combine those, and you have a hugely sensitive information detection system and a very, very high resolution, right, structural system to look at.
Thank you.
Okay, fantastic, Issam. We have another question from Brian Aldridge. Brian, would you like to ask, or Issam could read it?
Okay, let me look at the chat box. Yes, I'm going to read it. With some of the imaging modalities and outcomes that you are discussing, I wonder whether there might be some better animal models for the pathogenesis that you are describing than just mice. So my answer would be absolutely. I just don't. I mean, the studies that were done, they're mice, but could there be a better animal model? I think absolutely. Frankly, I think if there's a large animal model, that would be much more relevant, for human translation. And so I know that Professor Aldridge. So So certainly, if we could begin to look at other animal models for this disease entity, would be much more relevant and translational.
Well, I would suggest
Issam, and I was
using the
thinking,
pigs.
yeah, I was thinking
would
pigs
be
as
one.
well, King. Yeah,
Yeah, absolutely.
I was
We
thinking
have
pigs
done
too.
a lot of pig experiments in the brain, and the animal research sciences, they have tremendous pig models that you
Yeah,
can use.
obviously the only thing is the expense, right? So obviously, you know, but yeah, I think if obviously there's a grand potential, and pigs can be one, that would be very new and very novel, because I have not seen hard brain injury model with pigs, right? Even though I'm sure they would probably find the same thing.
Yeah.
And listen, I was thinking there's so many different pathways that you described, right? There's vascular pathways, there's neural pathways, there's inflammatory pathways. You almost want to work at, before you come to therapeutics, you almost want to work out what's the predominant pathway in this potentially multimodal linkage, which you laid out really exquisitely, I think, in your presentation. So, but for therapeutics, you go, this is the major, you know, mechanism, and that's the one we want to focus on. So sort of unraveling those as well might be important as well.
Absolutely.
Are there biomarkers, right? Are there biomarkers for those things as well?
Or you knock out the neuronal connections, right? And then see whether you have the same information or not, and see whether those neuronal connections are actually important for this information to occur, right? In a pig, it's much easier to actually knock out those neuronal connections and see whether they have any influence. If you have a tool that can actually detect the information, and then it's very easy to create a MI model in the pig, right? And then you can knock out some of the neuronal pathways and say, hey, if I knock out this neuron pathway, do I still see the information, right? If you do still see the information, then those neuronal connections may not be as critical as we think, right? And then you can dissect out the importance of the different types of connections by this type of elimination type of analysis.
So I'm going to invite all those with great suggestions to join the neurocardiology group, because I really think they're all great ideas. And I think we need more people, frankly, right, with those experiences to sort of to move to the second stage. And I think every single suggestions, you know, by Dr. Lee and Aldridge, it's absolutely true. And I think there are, Dr. Lee, there are already minimally invasive way to knock out the cardiac brain connection without actual surgery, right? There's chemicals, all sort of things. So I think these things can certainly be very, very sort of precise ways to begin to figure out the dominant force, even though at the end of the day, we know, right, that most likely it's all of them participating. The question of what is the trigger, what comes later and earlier, and obviously that's going to takes lots of work.
Absolutely, but then that help you, right, guide the potential treatment. If I know what's the dominant pathway that causes it, then you have a treatment that is potentially available. If they're all together, then it's very tough. If it's a summation of many, many different things, then it's much harder to think of a way of mitigating. But if you have a dominant, right, pathway that causes the inflammation, and the inflammation does cause the subsequent neurocognitive problems, then you may potentially find a way to treat it.
Agreed.
Okay, and I was thinking that some of the neurocognitive measures might be more precise in the pig as well, right? Where with the mouse, you kind of, if it's appetite and choice of food, the pig, you can do a lot more. So if your depression is quite hard, right? I mean, there's so many different levels of that. So you maybe that pig would be better for your outcomes as well. Isn't as what I was thinking.
Absolutely.
As well as the model.
I like the pig model fantastically, and we are very good at that too at UIUC. So
yeah, just to add to that, I put it in the chat. It's Ryan Dilger here at ACES is a world leader in this. Actually, he built out in the middle of the cornfield this pig cognition and nutrition laboratory. It's an amazing thing. He's got literally piglets in cages with cameras, and he's got AI algorithms judging their behavior, their social interactions, and he's got all of these field tests for their memory, and then he's actually working with Beckman a lot to do MRI on the brain. and associating that back to behavior. So if you're interested, I could make the introduction. I think there would be a tremendous synergy for what you're talking about and the piglet model.
Yeah,
So-
I'm already a strong collaborator with Ryan, who have just finished our first study, ready to submit a paper. So he's a fantastic collaborator. If you want introduction, I can introduce him too.
So I would say I was going to take this a little bit for the broader issue that I've been for 2.5 years, really, right? And this goes back to, for us, what are we going to do with this connection between clinicians and scientists? For 2.5 years, I could not identify anyone, even though, right, we have world-class people. So I really think we need to take this forward and try to figure out a way how clinicians and scientists can meet up early. I hope I gave this talk 2 years ago. I think we'll be a lot more advanced than now, but it's never too late. But thank you. Yes, absolutely. I would like the connection, and hopefully, again, figure out a way to have those connections early on and more systematically.
I think this forum is not a bad forum for us, right? To gather.
It's a great forum, but I think, unless somebody is, I mean, it is, but we need to get more people. And I guess you're right. This is a very good forum, but it may not be enough. We need another, and hopefully bridges. Well, I'm sure we'll figure that out.
Okay.
Let me just add another thought along these lines, and that is, while you're talking about the optimal experiments to do to get at the mechanistic nature of the relationship, which is what good scientists do, so keep doing that. At the same time, what even the promise of this paying off suggests is the collection of more than heart data in cardiac patients, and the regular collection, the ongoing collection, and the ongoing collection of more than brain data with people who have, or psychiatric data with people who come in through psychiatry and neurology. And that's a within clinical enterprise sort of issue. How do you, with sufficient evidence of the linkages, begin to, as a matter of course, collect the kinds of data that would permit you to go forward in the clinical space? If these things truly are related, collecting these kinds of data, not just in 20 individuals, I know that's the pilot study, but the goal is to get as quickly as possible to the kinds of biomarkers you need, right? To, as a matter of course, collecting data that cuts across those disciplines, permits you to see those relationships, permits you to do those predictions that you talked about at the outset and the like.
So this is a great idea, and I think this really goes into what are we discussing now. So let me give you the specific pathway for that, right? So we're talking about creating, a clinical or translational research pathway. One pathway could be neurocardiology. We met yesterday with Geese faculty who are interested in analyzing clinical data with the clinical and business intelligence unit in Carle. We could, right, go and mine data and get data for patients who have heart attacks and see whether they have depression or see whether they have other. So actually, that project can be implemented, but obviously all that needs a little focus, teams, and plans. But I agree that would be a very important parallel database or project to corroborate the other parallel translational foundational project. So it's doable, but it needs sort of
medical students. I think our medical students would be perfect, right, to engage in this project for a couple of years, right? So.
Exactly, but I think medical students with the clinicians and basic scientists, and that's why we talk about translational pathways. Each pathway would have medical students, clinicians, and basic scientists, engineers would be focused on that pathway, so there's capacity to dig deep. And so, absolutely, this is something that hopefully we'll discuss more in the short term.
Well, and I think you also need the funding mechanisms, right? So
that's correct. I've been talking to you, Jessica, for a while. You've been helping me a lot, but I'm still going to try.
Yeah, we're going to keep working on that one. The whole idea of doing pig studies, that works right into some of the processes that we're trying to develop out for the research funds that we're actually getting into the College of Medicine. So, as we start to develop out what that looks like, these kinds of things are good examples of why we need funding for from donors, not just, you know, NIH and things like that. We can get that funding later, but let's focus and see what we can get moving now by being able to describe what the opportunities are. So it's exciting work.
That sounds like a great place for us to both end and begin, Jessica. So I will use that opportunity to bring to a close a really fantastic discussion. And Issam, thank you so much again for taking the time to deliver such, as you can tell, an inspiring and thought-provoking lecture to our CI Med community. And we're really looking forward to all the follow-up that I'm sure is going to happen. Okay, thank you so much. Thanks to everybody for participating. Have a great afternoon and weekend.
Thank you.
Thank you.